Talking gait cycle assessment. Wow. As I said, one of the first things that you might be able to notice is just the pacing and the sound of the gait. And if there's kind of that might, depends on what environment you have. Some places don't resonate as much. But if you can just, if you could put a metronome to their steps, right? It should be like 1, 2, 1 and 2 and 3 and 4 and 5 and like everything. If you could synchronize essentially where their knees are when they're in the swing phase, if anybody's talking eighth notes, 2, then 1 and 2 and 3 and if you could just kind of put that pattern in your mind and watch and see, are they rhythmic or dysrhythmic? Rhythmic's going to be better. So that can give you kind of just a quick initial cheat of to indicate, is there something off? And most people are going to be a little off, right? Breaking into these cycles, this ends up being some kind of stance phase. You have like a pre-stance to eventually a terminal stance. It's easier initially to think about, and this does get called heel strike, but this doesn't get called like push off. So, but terminal stance seems to be more common. This is the place where like the toes are still on the ground and you're about to like actually push off. Now, from the heel strike, in order to accomplish that, you need dorsiflexion. If you don't have that, maybe you'll get there, but it's not going to be as efficient. So you need dorsiflexion to pull that off, and you need knee extension. If somebody can't extend their knees fully, then you can see how that's going to offset how they're going to heel strike. And then you may see one, depending on the clothing, but you're going to register that their foot doesn't look like it's lifted up off the ground very much. Some part of that space between the bottom of their foot and the ground is less. And both the knee and the ankle could be a factor there. Now, once we're actually placing our foot on the ground, once that is flat, now we're going to be in this loading phase where we're shifting from our weight being on this leg to this leg. And the body has to be good at a whole bunch of stuff. There's some sneaky proprioceptive elements happening to just transition our way to fully bearing our weight on this one leg from the other. And that loading phase, they'll call it like accepting the weight of the body. And then we're in this cycle from here to when this leg behind me is lifted off. That's essentially the loading phase. Now we're here, we're in this mid stance. But at a mid stance phase, what we're actually talking about is balance. It's going to be single leg stability. So as a general cheat, what I tend to think about, I want you guys to ideally be able to think about, is identifying, is the issue in the single leg stability component here? Or is it relative to the ability for like the hip to freely go from hyperextension into flexion? Is it about the knee being able to go from flexion to extension, vice versa? Is it about the ankle? So is it about joint mobility? Is it about mobility, or is it about stability? Right? If you're going to just discern those two, frankly, that'll take you most of the way of where you need to be in terms of what you'll target, because the rest can be maybe more efficiently in terms of how we function clinically done on table. Because then if you incorporate your joint movement, as we did last week, into the session, you would be able to see, oh, they really do have limited ankle mobility on this leg compared to the other one. That makes sense that I saw that leg not functioning as evenly during their gait. And so you can kind of process your way through. So once we're in that loading, heel strike to loading, now in this mid stance phase, we're in the single leg element. I have to bring that leg over, so this ends up being the swing phase of the other leg. We're in heel strike here, but once we're in heel strike here, we're going to be transitioning into this terminal stance phase. The terminal stance or push-off phase thing that is essential there is toe mobility, especially your big toe, but all your toes. If your toes cannot go into extension enough, then you're not going to be able to go into this push-off terminal stance phase. Another reason for limitation there can be super tight Achilles tendon. So if this stuff behind the ankle, if the plantar flexors are too tight, then they limit that and you'll get some kind of quick heel lift. And it could be for toes or Achilles. It's sneaky, it's hard to tell initially when somebody's walking. It'll just kind of be this subtle, usually kind of jerky. If it's more jerky, it's, and in my experience, it's more Achilles, like real tight soleus gastroc, something like that. But it could be the toe. It might be both, because those big toe muscles live right adjacent to all this stuff. So toes to ankle, essential to be here. And if we can't get here, this is one of my big things. If the big toe can't get here, and if the ankle can't get here, then something's going to be less efficient. And why in practice, one of my hacks always was to make sure I was doing some kind of toe mobility while I was working in the calf and the foot, like anywhere lower leg and foot, grabbing hold of those toes and moving them around, as well as the ankle, and just trying to get that, symmetrical, and if anything, keeping it as efficient as possible. If the ankle and toes aren't efficient, then everything up the chain is going to be way worse. The lower the issue, the more body-wide it's going to travel, and vice versa. You'll usually hear, related to kinetic chain, the principle of thinking about how things transition their way to affecting the foot, even if it starts higher up in the body, or how does something in the foot travel up the body. And systems like Rolfing, for example, will focus on the foot and the lower leg for a whole session and work their way up the body. Like their construct is you have to address this first and then work your way up the chain. All right, and knee. Well, knee, nice thing with the knee is it's just a hinge joint, so it's pretty easy to distinguish. Is it going into extension and flexion? Especially, is it going into extension? Extension, when we're loading our knees, is the point at which the bones are going to be closest to each other. So if there's an issue in there, a weird meniscus, a floating body, some effusion, osteoarthritis, typically what occurs there is limitation in being able to go into full extension. People will be stuck. They'll gap the joint because there's a closed pack position when the bones are the closest they can be to each other, essentially. That tends to be in starting anatomical position, full extension. If my elbow's in closed pack, my knees are in closed pack. Once I free that up, I'm in open pack, but there's a little bit of a gap. Why recliners are so comfy. Puts you, everything's kind of in this slightly flexed position. That tends to be this open pack thing. Why that Tai Chi stance tends to be something where it's taking the stress off the structures of the bones and the joints and placing them into the muscle and connective tissue. So why, when people have postures and positions that rely more on structural stability, meaning the bones and the joints, what they'll look like is their knees are really extended. They bring the weight of their body more over down onto their spine, and they end up kind of more like that. And that's inefficient. The joints are at a range where they're being compacted more, and the person then secondarily is not using their muscles to support the weight of their body and stabilize their joints as much. So ideally we all get good at it. And also being able to get out of that though too is the thing. You do need this full extension where you have like a full lockout. There's a little bit of a rotation element there for like a screw home, like where it can be really good and stable. Because at a fully closed pack position is where I'm going to have the most stability without using my muscles. So for you as a massage therapist, where do we use closed packs so that we're not fatiguing ourselves? That leg, this arm. Why you need that heel to be driving down, so the energy's transitioning through these bones right into the floor. But then I'm using that structural stability and the weight of my body to deliver force, as opposed to now it's all muscle. Okay. With the swing phase, the only point I really want to drive home here is that the way we accomplish this kind of swinging our leg around isn't actually very much specifically about rotation. The rotator muscles of the hip really, they need to allow some changes of shape, but it's like subtle. So the internal rotators are more or less here. Tensor fascia lata, the front fibers of gluteus minimus and medius. So think pocket. Greater trochanter forward to about the anterior superior iliac spine. Okay? Right there, internal rotators. The external rotators are all back there. So kind of like front-ish, superior to the greater trochanter, and posterior, inferior-ish. Right there. And then this gives me some eyeball navigating that way. There's all the deep lateral hip rotators, 6 of them there. The internal rotators would be right here.
So those lateral rotators are really under the larger muscle of
Gluteus maximus.
Okay.
Yes. So that's why that forearm placement has been driven into you so much. That there's a forearm placement that goes here, and then you can get more specific on that, but to get gluteus maximus, and you can be right along the iliac crest, like coming pretty close to the SI joint. You can be right in the belly of it, or we could drop our arm in such a way to be more on the lateral aspects of it. Now, directly underneath of it is gluteus medius, and then a bit more anterior to that is gluteus minimus. So those, especially medius, is also involved with abduction. Now that's its main job, and then its second job is also internal hip rotation. But why? Forearm here, like this, a bit more aligned where your placement's going to be, let's say your arm seems in line with their leg, versus changing your orientation so the arm's more perpendicular. That'll get you on 2 really important muscles, gluteus maximus, gluteus medius. Then if we come further down, find that greater trochanter, apply pressure here, and then when we're moving that leg back and forth, we're getting that friction to free up all of those. And just recognizing too, those cover some space. So you can be, more superior and work your way more inferior. And be on, and I tend to find, frankly, like piriformis yes is a thing, but something that gets missed are these lower ones. Like quadratus femoris. Remembering the 6 of them was always a journey for me. And it got easier when I started always forgetting one in particular. And the hack with the leg muscles, quickly visit, 3 hamstrings, 4 quads, 5 adductors, so 3 hamstrings, 4 quads, 5 adductors, 6 deep lateral hip rotators. Not too bad. 3 hamstrings, there's a bicep femoris, like there's a bicep brachii, bicep to bicep. Then there's 2 semi-somethings, semi-tendinosus, semi-membranosus. Semi-tendinosus is on top of membranosus. The quadriceps aren't that bad. You have a rectus femoris, so bicep femoris versus rectus femoris. Femoris means rectus means the middle of. You have a rectus abdominis, your 6-pack muscle, so rectus to rectus on the femur. And the rest are named vastus, just for where they're located. Vastus lateralis, vastus intermedialis, and vastus medialis. Adductors, not too bad. 3 of them are named adductors, something, but the other ones are weird. There's gracilis, which is this long cord. I think gristle, so gracilis. Then there's an adductor magnus, adductor longus, adductor brevis, and then there's one really high up that I used to forget, but when I was thinking about how a ball and socket joint paired with ball and socket joint, your pecs are your adductors of your shoulders, and your adductors is a pec called pectineus. So the most superior and smallest of the adductors is pectineus. All right, and we'll revisit those again. These, the 6 deep lateral hip rotators, there's a famous one called piriformis, and then there's a couple doublets. So there's 2 gemellus, or gemellus starts with a G, gemellus superior and gemellus inferior, or gemellus. I feel like gemellus sounds a bit, I don't know, nicer, but obturator, internus, externus. What's nice is you just really have to remember one of those terms, and you know there's one for, there's an inferior, superior, internus, externus, and then a quadratus femoris. But what helped me, because those are a lot of weird, alien Greek and Latin terms, what helped me a ton was knowing how many I'm trying to get through. So 3, 4, 5, 6. Done. Weirdly enough, this muscle, if you're gonna fall out, let's see where in here. That's not worth it. Okay. Sartorius. So this dynamic here, up here at the, ooh. So we just talked about those quadriceps muscles. Only rectus femoris works at the hip. It is a hip flexor, along with, now that's its prime action, along with these 2. So that's sartorius and tensor fasciae lata. So the 3 of them do work regarding hip flexion. They concentrically shorten. But these 2, look how they split and create like an upside down V here. Kind of a cool dynamic of how they come down in one. Tensor fasciae lata becomes the IT band. The IT band is essentially its tendon, a case where the muscle is smaller than a tendon. On the lateral side of the knee. Sartorius comes all the way down and goes on the medial side of the knee. So how you would have muscles that maybe be related to a person's lateral medial knee thing, but they're all the way up here in terms of the actual muscle belly where you're going to be able to affect their tone more readily. Okay? So being able to plant a forearm here, why that's so essential. To be able to get a forearm placed there. These are always going to be chronically tight. I mean, the only person I can think, the actions, like a person that swims all the time, maybe they'll be more extension dominant, but most people are going to be way more flexion dominant. So being able to place our forearm here and then work just more minutely and precisely. Do I go a little bit higher up and maybe a touch medial, just below that anterior superior iliac spine, or do I go just a touch lateral? And I had gotten done talking about how tensor fasciae lata is one of those internal hip rotators as well. So important. This one though, it has a crazy series of functions because of how it's oriented and designed. Sartorius, is involved with hip flexion, but because it comes over onto the medial side of the knee, it also does external hip rotation and flexion of the knee. To make sartorius do all of its actions and to like isolate it, make all the fibers work as much as they possibly could, I would do this. Flex, externally rotate, flex, externally rotate, and flex my knee. That's how I would shorten that crazy S-shaped muscle.
I call it the hacky sack muscle.
Oh, that's very good, yes. That's much better than the Taylor's muscle because nobody knows what that means anymore. They used to call it the Taylor's muscle because it would be if you put your foot up. And so I guess a Taylor was working on it. So anyway, hacky sack, I love that. But that means we have an external hip rotator and an internal hip rotator living right there. So just important place, important place. Now, coming back on my centrical way of doing things, my cyclical way of doing things. During the swing phase, those rotators have to work to try to, in an ideal world, keep your toe forward so that when I am pushing off in that terminal stance phase, if that toe is off to the side, I'm not going to get that extra oomph. The ankle and the knee aren't aligned correctly. There's going to be more stress on them if I push off like this. Like a twist there is bad. It's always going to cause asymmetrical stress, especially in the knee. Think how the knee is just a hinge joint. All it really wants to do is move forward and backwards. So if you twist it and then start putting stuff on it, it's a bad time. So too rotated, not good. That's putting weird stress. So what the rotators have to accomplish is, as this leg is back in hyperextension, to keep the foot and the knee aligned in the sagittal plane. Then I push off and I bring it all the way around and ideally have it lined up again for an ideal heel strike so that weight transfer is also equal into the ankle and the knee. So the rotators kind of do some small actions, but they're really just trying to control. They're just going, don't swing out, don't swing in. If you swing out too much, then it's going to be something like that. Or you can have like a more of a pigeon-toed kind of a thing where somebody kind of, all those are going to lend themselves over time. And some people might be miracles where it doesn't like cause a problem, but those little micro movements done inefficiently enough could lead to something bigger over time. So what's actually happening beyond flexion and extension here, and the rotators keeping things stable and aligned, is that it has to be a abduction with flexion, a deduction with flexion. Okay? And we'll do it again. So once I'm bringing that leg up off the ground, a abduction, swing around, a deduction. So those abductors are essential in even being able to do what people can sometimes misinterpret as a rotation pattern. But it's really, really more flexion and extension coupled with adduction and abduction to do that. And there is kind of a swivel component occurring at the pelvis too, where the spine has to be allowing a little bit of lateral flexion and rotation. It's kind of like the runway walk where there should be some kind of, not too much, because if the pelvis isn't stable, you'll start to get like a hip drop or one. I can't even really do that one very well. But so now what is required there? If there's even that, it's again gluteus medius. It's going to be an abductor. So yeah. Swing phase, stance phase, swing phase. Swing phase, if you were to see something weird there, then we might want to think about, are the rotators and or abductors, adductors a facet? But I may look at if they are not accomplishing this because the foot's too externally rotated or they're striking with their foot too internally rotated, then I would think rotators. Flexion and extension will certainly always be a factor, but with the stance phase, if they're not loading appropriately, that may be more of an abductor, adductor component. This is just beyond flexion and extension. Now, I really do tend to say, always assume people are short and tight here. So if they're too short and tight here, then they're not going to get their hip back far enough, and then everything's going to look bad, but it might just be here. So to break those down, we watch a person, we try to monitor all this, pick one and then the other, pick one leg and watch like a full stride cycle of that. Watch my right leg go through a couple rounds, and then you'd watch the left leg through a couple rounds. See if this stance phase, heel strike component, ideally eventually you get to the point where you're looking at how does that heel strike compare to that heel strike? How does that loading and stance balance compare to this loading balance? How does this heel strike, how does this push off terminal stance compare to this push off terminal stance? And again, the cadence and all that. Working our way up, and then yes, of course this. And watching those toes. If you can get behind, you need to usually be right behind the person in front of them to just see that those toes are lined up, you know, where they're actually going. Big toe, where you're going. And then moving up, if a person is like drifting, you know, does their whole torso just seem to only go one way? Right? You can't get lost just in the legs. You can see, are they laterally flexing at their low back as they do this too? You know, kind of have, you know, usually things are more subtle than what I'm showing, but it'll just look like the whole side of the body drops like that. So that's looking at a little bit what the low back and the shoulder girdle could be doing in response. And it could be because of the low back. Yeah, that's where you'd have to start dissecting. Like, is this happening because something's really short and tight here, and that's affecting it all? But given enough time, if somebody comes in and essentially, I don't know, they could have been walking like this for 10 years, right? That's going to mean that this is all changed and become unified in this distorted gait function and pattern. And so it'll take a little while maybe for you to decipher, if you'll ever even know what the root cause actually is. And then arms. Ideally, we do swing our arms at the shoulders with our gait. I see a laugh, but there's a lot of this exists in the world, right? And usually you'll see it coupled with a smaller step / stride, kind of more of a shuffly kind of tendency. Now that could be a couple of things. If I have neck and shoulder issues, then that may be a factor here, right? That we've already talked enough about how this is so linked. But if I'm rigid here to protect my neck, how is that going to translate to this kind of pendulum counterbalance effect that we are supposed to ideally use as we walk? Because there is this, the efficiency comes from, I'm not even doing that, here we go. You have better balance if you're counterbalancing it, right? So here, the adaptation would be not to stand like this, and you're not going to usually see a person not moving their shoulders with a big stride. They're going to have a smaller stride relative to this because there's going to be that correlation. So ideally, yes, the contralateral shoulder flexes with the hip. So if the left hip is moving forward into flexion, right shoulder forward into flexion. This will be the component that we're going to pay attention to the most once we're assessing on table, is this action. So looking left to right, and then right to left, thinking flexion. And I spent a lot of time doing a few actions in my body to help confirm these movement patterns when I was just starting out. One being, this is all my flexions, aside from being able to curl my toes, you know, into like a fetal position. If I curl up on the ground, it was like this. That's all my flexions, all my extensions, all my hyperextensions, including the wrist, You're not even gonna hear me do that, say that too often, it's like getting pedantic, but hyperextend elbow, right? But all flexions, all extensions, all hyperextensions. Then going into the gait stuff, thinking, okay, now this will further go into if the ball and socket joints are paired relative to gait, so are the hinge joints, so are the modified condyloid, so is the wrist and the ankle, thus so is the elbow and the knee. As above, so below. Now, the neurologic pairings will still exist there too. If there's something up here, it may cause an added effect over here. Just like how this would have an effect. And maybe even ankle to wrist. I don't see that as often because these aren't, the hand and wrist isn't quite as load bearing, but you can make a neurologic pairing argument for the muscles that work at the toes and ankle to the wrist and the hand. From the knee to the elbow, from the hip to the shoulder, from the low back to the neck. So there should be a little bit of elbow flexion too. It'd be odd if it's, elbow straight. So there should be some elbow flexion with this too. And then again, looking at there's even a touch of pronation, supination, internal rotation, external rotation. Those are the minutia. Know that that exists. It makes a lot more sense initially to worry way more about just this basic leg stuff and the shoulder, the contralateral shoulder action. But there's at least some kind of shoulder action. And then is one way more than the other? And that even may kind of show you something where there's almost kind of a throwing that arm and shoulder forward. To kind of let gravity and momentum carry a person. Not dissimilar to a person like really needed to oomph their way out of a chair. Right? Now, that's where we get to looking at these pictures real quick. This is page 455. We'll come back around to this. What I want to start you out thinking about is the blue to the greens. Just don't even worry about the red arrow. Try to blank it out from your mind, okay? See how that would be if I'm assessing, this is muscle testing. This will phase us nicely into muscle testing / strength testing. Really, the more ubiquitous term is muscle testing. Strength testing might have to do with like how much you could actually lift at max kind of a deal. So looking here, flipping, green to blue. The blue is just the control. So what these pictures are indicating, first I'm assessing the shoulder, making it the control. If I activate the shoulder, does the opposite hip activate too? You know what I'm saying? If it's shoulder first, does the hip know it's supposed to follow suit? Then we go, if I activate the hip first, does the shoulder know it's supposed to follow suit? Is this pairing, is this neurologic reflex occurring appropriately? That part isn't too bad. Then it will hurt your head, and I have a nice hack for how to figure this out with how you place your body relative to theirs, because you're going to be applying pressure. You have to apply resistance so that you know whether or not they're strong or weak, right? So you're going to have to apply resistance where the green arrow is and where the blue arrow is. If it's contralateral, if I'm trying to speak to this shoulder to this hip, we're going to be applying our resistance at the distal ends of the long bones. So I want my resistance to be at the distal end of the humerus, the distal end of a femur, and it's just so I have more leverage and they don't throw me. It will be either on the anterior side or the posterior side. This one doesn't flex its limbs, but my hand placements will either be both anterior, both posterior when contralateral. Yeah. If, going to the next pictures, we're looking at same side action, then my controls will be opposite. One arm anterior, one arm posterior, one arm posterior, one arm anterior. That's kind of going to be the quick hack. You've heard it once, we'll come back to it. To go into that component further, it's just that we're talking about initially this action, looking at the hip and the shoulder going into flexion. But then we have to be thinking what's actually happening on the same side of the body as we do this. Now it flips. This hip is going into extension and hyperextension while this shoulder is going into flexion. So the things I would do to try to remember this is it's this, and then it's this. That becomes a fun exercise. Okay? Now if it's, so it's this to this. So it ends up being like I would bring my knee and my elbow like this to here. That's the same side action. And why, to apply resistance, it would be anterior to posterior, or anterior to posterior, to see if that is occurring well. And we'll come back around to that. The next part's going to be just doing a little bit of gait assessment on each other and picking on how everybody walks.